Okay, so next I'm going to introduce Dr. Ron Dahlman, who is the Journal of Vascular Surgery editor of Brands and our new editor of Brands, who hopefully will say a few words to kick off the webinar.
Thank you, Alan. Thanks, everybody, for inviting me to participate today, and congratulations on a really exciting lineup of presentations today. I just wanted to have a chance to acknowledge the leadership that the editorial team for JVS-VS has shown in terms of developing this newest platform for the Journal of Vascular Surgery family of publications. The innovation that you've brought to the way that your editorial processes are organized and how you're kind of helping highlight some of the really exciting advances in vascular science. And we look forward to further development of a lot of these concepts as we, recognize the contributions that our author community is making to the advancement of vascular science, and also the kind of the need for a platform for translational research in vascular science, where I think this journal really fits a compelling need. So congratulations, everybody, and looking forward to a great webinar today.
Thank you so much, Dr. Dahlman. We really appreciate the opportunity to have highlight in the JVS family brand. One of the things that we've noticed in the JVS Vascular Science Journal is that things that we do in our journal can be tested, perfected, and then rolled out to the rest of the family. So this is something that we're really excited about. And these webinars are another opportunity to showcase what we're doing and also test the ability to do this across the family. So without further ado, I'm next going to introduce our associate editor, Dr. John Curci, who will be running this webinar. Dr. Curci.
Thank you, Alan. Thank you, Paul, and really appreciate Dr. Dahlman's presence here and interaction with our group. I'm very excited by this presentations today. You know, what we picked today was specifically chosen to highlight research publications that examine the interactions of novel devices with the vascular system. And these experiments will highlight for you today the progression of our interventional techniques from ones that treat vascular system as just a static conduit or static tube to one that's more complex and nuanced, an understanding of the biologic systems of circulation as they interact with the things that we do to them procedurally. And those two papers are fantastic. And then we have the wonderful addition of an invited talk from Dr. Roy, who has a particular interest in this area and will really round things out for us today. Dr. DiMuzio, I believe that while we're talking here today, while these presentations are going, people will be able to use the chat function to provide questions that I can then moderate to our presenters today. And we'll go ahead and jump right in at this point. Our first talk will be from the lab of Dr. Louis Schwartz at the University of Illinois. And that talk will be on the intravascular treatment of long segments of experimental peripheral arteries with multiple serial balloon-expandable resorbable scaffolds. And the first author on this was Dr. Rim El-Khoury, who unfortunately wasn't able to present today. Dr. Schwartz?
Well, thank you all very much for this kind invitation from the Journal of Vascular Surgery, Vascular Science to present some of our preclinical work. A few apologies. Number one, which you would see in the video, that I have gotten older, although I don't look quite as old as Dr. Dardik, so I'm not quite as scary. But number two is that I'm definitely not Rim El-Khoury. Rim is the vascular fellow at the UCSF that I work closely with. But my name is Lou Schwartz, and I'm the senior author, and Rim asked me to step in since she's doing a mesenteric bypass. Unlike Rim, I do have several disclosures, the most important of which is that I'm the founder and chief medical officer of this company, which is called Efemoral Medical. As we all know, peripheral arterial disease is the scourge of our time. The incidence is increasing, the severity is increasing, and we are left here with only few solutions. I note the best CLI data, which are welcome, but if you notice, both arms did rather poorly. I think we can do better. And the way we do better is with better devices. There are many on the market, many more coming. The best device really for human arteries at the present time is a balloon-expandable stent. A balloon-expandable stent is one in which is a rigid device resides inside the artery without moving, and the artery can heal around it. And if you get the artery to heal around a balloon-expandable device, then one can expect long-term patency. The self-expanding stents were quite a welcome development for their time, but they interact with the artery too completely. They bend and twist and scrape, and so the patency continues to degrade. And that was one of the primary design inputs of this device, that balloon-expandable stents were preferable for human arteries. But one cannot place a long balloon-expandable stent into the femoral popliteal segment for obvious reasons. Balloon-expandable stents are rigid devices, so they really only work in arteries that either don't bend or bend minimally, and such is not the case in the femoral popliteal segment, which bends profoundly. So it's a problematic set of design criteria to try to both implant a balloon-expandable stent into this artery and still allow it to bend and deform. This is an article from a long time ago from Julio Palmas. One disadvantage inherent in this graft configuration is the lack of longitudinal flexibility, which limits its use in straight arterial segments, or in the case of curved arteries, requires the use of short graft lengths. So one can implant short graft lengths, multiple short grafts, short stents into a long artery that bends. The artery will bend in the intervening segments, sort of like a train rounding a tight curve. The objectives of this preclinical study was to design a bioresorbable polylactide-based scaffold with sufficient radial force to withstand lower extremity movement, and to assess arterial deformation after long segment treatment using serial scaffolds. A similar purpose was to test the scaffold integrity after exaggerated mechanical stress in an animal model. And our overall hypothesis was that long segments of mobile arteries can be effectively treated with multiple short balloon-expandable resorbable scaffolds. This is very simplistic device in this experiment. More longer, complicated devices were used in subsequent experiments. This is a polylactide-based scaffold. You can see in this experiment, 2 short scaffolds have been mounted on a single balloon. The scaffolds are closed cell, which means that in a closed cell configuration, when the balloon is expanded, the scaffold will shorten. And this, in fact, is a design that's exploited in this experiment, because the shortening of the scaffolds creates this space, and the space is desired for movement of the artery. The other important feature of a closed cell scaffold or stent is that they're very strong. As you all know, one of the challenges in creating an effective resorbable scaffold for the human arteries is that they're made of plastic, essentially, and it's very difficult to create something that's plastic that is strong as metal. Well, it turns out if you change the design some, you thicken the struts, and you make the scaffold pattern closed, then the radial strength can be made equivalent to metal. The model that was used is the porcine iliofemoral model, and it's used because of its extreme bending. Here you can see an angiogram of the pig with the hind limb extended, and here you can see with passive flexion with the animal anesthetized, the artery bends profoundly. The artery bends in its iliac segment, which is here. I don't know, can you see my pointer? Probably. But the the artery bends minimally in the iliac segment, which is the most popular segment for preclinical work. But in the iliofemoral segment, the femoral segment, there is profound bending. And if you measure the amount of bending and axial compression in the femoral artery of the pig, it is more numerically than in the popliteal artery of the human. In this experiment, manual flexion of the swine hind limb was afforded after scaffold implantation, and the amount of axial shortening and bending was measured using planimetric methods. Scaffold apposition to the arterial wall was assessed in vivo using optical coherence tomography, which many of you may be familiar is a light-based intravascular imaging modality. And then explantation of the stented arteries after animal sacrifice was performed. This device is created with only 2 scaffolds. So in order to fully scaffold the artery, multiple device implantations were made in the same artery. All in all, in 2 arteries, 2 scaffolds were placed. In 2 arteries, 4 scaffolds were placed. In 3 arteries, 6 scaffolds were placed. And in 1 artery, 8 scaffolds. And this way, a fully scaffolded, if you will, artery could be assessed. The total arterial scaffolded length ranged from 3 to 10 centimeters. And here's an example. On the left is a porcine iliofemoral artery treated with 4 scaffolds. The scaffolds are made of PLA, so you can't see them. Here, the artery is bent with a manual flexion of the hind limb. And you can see that even though these are balloon expandable and rigid, they are short enough so that the bending is unimpeded. And this was the point of the experiment. Here's an artery in which 8 scaffolds were implanted. So there are scaffolds implanted all up and down this artery for a length of about 10 centimeters. And here, with passive flexion of the hind limb, you can see that you can sort of imagine where the scaffolds are, but you can see that the artery can bend unimpeded. And this is the hypothesis of the experiment, that one can implant an artery that bends profoundly with multiple short scaffolds and not impede its ability to bend, and not to pinch the artery to compromise, such as the lumen would be compromised. And here are some numeric data to this effect. In the non-scaffolded pre-procedure controlled target arteries, you can see that the arteries were bent only 15 degrees in extension, but then a full 110 degrees in flexion. And that flexion did not compromise the lumen. In fact, with flexion of the artery and axial compression, the artery actually got slightly nominally higher from 4.7 millimeters to 5 millimeters. Then in this panel were the arteries that are scaffolded, and you can tell that the amount of bending was approximately the same, 14 degrees to 113 degrees during flexion, and that again the arterial diameter was not affected by bending an artery housing multiple balloon expandable scaffolds from 4.8 to 4.7 millimeters. Now, this analysis attempted to discern in the arteries that compressed, what was being compressed, the spaces between the scaffolds or the scaffolds themselves, since the scaffolds are essentially stents that are a closed cell pattern. They can be compressed by compression forces. They can be shortened. Here is a graph that shows the length of the interscaffold spaces, the spaces between the scaffolds, and you can see that they generally decreased. So the artery, when bent, would compress the interscaffold space. This was expected. What was perhaps unexpected is that the scaffolds actually compressed slightly as well. So compression of the artery by bending the hind limb caused shortening of the scaffolds, as well as compression of the scaffolds themselves. This is how devices in the femoral popliteal artery of the human, this is how they withstand walking and sitting. The device compresses axially, and the non-treated artery compresses axially. Here's an OCT image. This is in life. This is an acute experiment, so the animals were not survived, but you can see in cross-section the scaffolds. OCT happens to be a modality that is particularly useful for imaging resorbable stents. So these are the scaffold struts you can see on OCT. And then here is a micro CT image. The way this is a destructive test. The way this is done is the animal is sacrificed, and the artery, the scaffolded artery, is excised and placed on the stage of a micro CT. And you can see how the scaffolds reside within the artery. This is not in life, though, so you do see some, once you excise the scaffolded artery, it does compress some, and there's no longer arterial pressure, but nonetheless, you can see how the scaffolds reside in the artery. As you may know, the development of resorbable scaffolds for human arteries has been plagued by fracture, and that was a specific design element of this device, which resists fracture because of its closed cell design, because it doesn't have to be flexible, and because of its relatively thick struts. Here's an artery treated with 4 scaffolds. This again is after the animal is sacrificed. And here's an artery treated with 8 scaffolds. In conclusion, from this experiment, we can say that long mobile peripheral arteries can be successfully treated with multiple short balloon-expandable bioresorbable scaffolds. Supraphysiologic hind limb deformation did not generate significant axial compression of the acutely scaffolded artery. Arterial deformation was effectively borne not only by the interscaffold spaces, but also by the scaffolds themselves. Subsequent experimental and clinical studies will focus on the chronic vascular response to this interventional strategy. And I will say that since this experiment, there have been several subsequent experimental and clinical studies. We have a long-term study now in pigs, which follows the kinetics of dissolution and the vascular response. And we've initiated a clinical trial in Auckland, New Zealand, using sirolimus-coated, these are called Efemoral devices, sirolimus-coated Efemoral devices. And we have some early results which were recently presented at Circe. So this is an ongoing project, and Dr. Dahlman's remarks about translation are exactly relevant, because this is a preclinical experiment that we're now translating into the clinic. These are our colleagues, both at Efemoral Medical and at Charles River Laboratories, which performed this preclinical experiment. Once again, I'd like to thank the Journal of Vascular Surgery, Vascular Science, for the privilege of the floor. Thank you.
Well, that was fantastic. Thank you very much, Dr. Schwartz. And it has generated a substantial amount of discussion in our chat, which is good to see. I don't want to give too much time to some of these questions, so I will ask that we'll kind of touch on a couple of them here, but others can, if you could respond to some of them, that would be great. So Dr. Dahlman mentioned that this is a great area for innovation and immense clinical need. He has a colleague that has done quite a bunch of work on modeling SFA and popliteal shortening and twisting, and you all should consider planning translational and coordinate with him. I don't think that's really a question so much. And then Dr. Roy asked, do you anticipate requiring vessel prep prior to implantation?
Yes. So in fact, the clinical protocol at the present time calls for balloon angioplasty first. It's similar to placing any balloon expandable stent. I'm sure many of you do direct stenting, but the problem in the periphery is always you're afraid of losing the stent if there isn't enough room in the artery to advance the device. So yes, we have been doing balloon angioplasty. So vessel preparation will be important. Alan asks, can these resorbable scaffolds serve as a reservoir for drug release? That's been a very tough design element, Alan, because the scaffolds are made with heat, and the heat tends to denature paclitaxel or sirolimus. So that's been a tough design element. So at the present time, we are spraying scaffolds the way that drug-eluting stents are sprayed. And then Ron talks about Chris Cheng's work, which is really a lot of this is borrowed from that great work. In fact, placing multiple short stents in an artery is not a new idea, but the question has always been, well, how long should be the stents? How long should be the spaces, et cetera, et cetera. And in fact, you can take some of these data generated by Chris and by some of our own studies and actually quantify the degree of bending and axial compression in both the superficial femoral artery and the popliteal artery. And using those data can actually create an equation. And we've done so. It's actually part of our intellectual property, that you create an equation by which the length of the scaffolds and the length of the spaces can be designed such that when the leg is maximally flexed, the scaffolds don't abut. So that's a good and insightful question, Ron. And we use those studies, actually follow very closely that work. It's been very useful in our development.
All right. Well, thank you very much. I mean, I think we could talk about this quite a bit, but we don't have the time to complete this here. I do hope that you'll reach out to some of the other folks with questions and touch base with them directly. All right.
Thanks, John.
Wonderful job. All right. I'm going to move on now to work that's going to be presented by Dr. Hibino from his own lab. The first author on this is Hiroshi Matsushita, and then the title of the manuscript was Novel Reinforcement of Corrugated Nanofiber Tissue Engineered Vascular Graft to Prevent Aneurysm Formation for AV Shunts. And this was applied in an ovine model. It's from the section of cardiac surgery at the University of Chicago. Thank you so much for presenting today, Dr. Hibino.
Thanks so much for the opportunity to present our work entitled High Kink Resistance Nanofiber Tissue Engineered Vascular Graft in large animal model. So in tissue engineered vascular graft has been there for a while to overcome some problem of the currently commercially available vascular graft, and mainly to overcome the main issue for some stenosis occlusion at long time, and also clot formation. And then tissue engineered graft can degrade over time because of this biodegradable material. Then the material itself will be replaced with a patient's own tissue, then which can create enteric cell layer, smooth cell layer that is supposed to increase some patency and long-term durability of the graft. This study has been there for a long time, for decades. There are several still issues to apply in the clinical field. And especially in this study, we focused to two main issues we have right now for this graft. One is there are many biomaterial has been used to create tissue and vascular graft, but still most of the graft is really kind of rigid. So when you implant into some place and the space is limited, like AV shunt is making some U-loop or like that, graft easy to make a kink, and that could be another reason of some difficulty to have patency. The other reason is this graft is still some problem for some mechanical property. So when we implant in the arterial side, very limited material can stay there for a long time. There is some tendency to create some aneurysm or dilation. If we use some strong material that have slow degradation, it can stay there, but those material can cause inflammation, it can cause stenosis. So mechanical property versus some degradation has been a problem. So in this study, we developed a corrugated tissue and vascular graft, which can prevent the kink. And we invented a specific method for reinforcement of the vascular graft. So here's an example of the explaining of our technology. So this graft itself is a PLCL nanofiber graft, which is one of the most popular nanofiber tissue and vascular graft, which has been studied for decades. With this graft, without having any corrugation, it's easy to kink. So we made a corrugation. We often see that this kind of corrugation in the background graft in the clinical used. In the nanofiber graft, it's sometimes difficult to create those things, but we developed some specific technology to create corrugation, and this gives us some kink resistance like this way. And then aligned with this corrugation, we put some specific suture. It can degrade or non-degrade the suture, can support this vascular graft. So in this way, this suture maintained there to prevent dilatation. And also at the same time, there is a space between the suture, which allowed some cells to infiltrate inside for tissue regeneration. So if caught with something in a very strong material outside, there may be some problems. But our hypothesis was when we create some coating with the suture, cell can infiltrate there and still can create a tissue. So we tested in vitro first and implanted in a sheep model. And then as an AV shunt is about 5 to 6 centimeters. from this arterial to venous, like a U shape. And this way we can test both the corrugation and the effect of corrugation reinforcement. So this is some first visual study to test some corrugation. So without corrugation, these guys are rigid material, this PCL, PL series rigid. So it's easy to kink like this way. But with corrugation, we can dramatically decrease the kink radius. So the shape is like this way, even though we put this 180 degree and we can still maintain a patency. And then on top of that, we put some suture around there to reinforce this corrugated graft. So in this way, the tensile strength is going to be much higher with the sutures. Without suture around this here, but with this suture reinforcement, in vitro study, mechanical property was stronger. And then this PU group is a kind of other control. This is not suture, this is just a coated outside, just to compare. But with the suture has a bit higher mechanical strength. But when we put this suture around there, we checked again the kink resistance. But even though we have a suture around there, still have some kink resistance. So we were able to create this graft design in vitro model. Then we implanted into sheep model I just showed before, and followed up to the 3 months. And then this is an AV shunt. So the venous side is, of course, it's going to dilate over time with the flow from the artery side. This line here is a kind of acceptable range based on some previous study that could dilate this vascular graft itself because it's sitting between the artery and the vein. And then this square circle is jugular vein, which dilate over time. Carotid artery, this closer circle is still there. And the vascular graft is between there. We tested different materials. So when you look at here, this one is a control PU. This is just covered. But these are our new technology with the suture to just polypropylene was stay there without dilatation. But when we use a different suture, more faster degradation like a PDO, which can dilate as a jugular vein, or without some any sutures, it can dilate as well. So the corrugation works well, and also, but at the same time, depend on some coating suture material. If you use some biodegradable, fast degradable material, or without coating suture, it can dilate. But with this polypropylene suture, can maintain a diameter and they still maintain a mechanical strength. This is a kind of busy slide, but we want to show is no matter what material we use, this is a nature of tissue graft. We can see endothelialization for all the tissues. And then we look at the carefully, depending on the materials, when we use this PU, just a coating to the outside, you can see there are not much tissue formation inside, especially in a high magnification here. There's a very coarse tissue. This is because this cover outside prevent stereo infiltration to the inside. But with our new technology here, just suture coating reinforcement, there is a space between the suture so the cell can infiltrate. So you can see that some small cell infiltration. And here, which can help some nail tissue formation. And with this configuration, this 2O suture, PDO suture, both as a good nail tissue formation. But as is shown before, if you use these PDO, 2O suture, both looks good in a tissue formation. But over time, this PDO suture degrade too fast, then dilate over time. But 2O suture with some reinforcement can maintain the diameter. So from these studies, our conclusion is that this 2O suture with reinforcement is a best way to register expansion and also to maintain a cell infiltration for tissue formation. So in conclusion, we are able to create a fiber vascular graft with the kink resistance and also the tissue formation with some reinforcements with a suture. Thanks so much for the opportunity.
Wonderful presentation. Thank you, Dr. Hibino. All right. I don't see any questions. I did have some questions when I was reviewing this. There was, in your paper, you suggest that the patency was changed, although I wasn't totally clear on the effects of adding that suture and corrugation to the patency of the grafts. Can you discuss that a little bit?
Yeah, in this study, we did not implant kinked graft. So all grafts were implanted already corrugated graft. So we did not evaluate effect of the patency, but in vitro study, we already confirmed that it's really weak for the kink resistance. So when we try to implant in such a configuration that we showed in large animal study, when you get this graft and without corrugation, it's easy to kink. So it's easy to tell that this won't work. So that's why we didn't do this in vivo study, that analysis.
So did you have any occlusions of these grafts that you implanted in the sheep, these corrugated ones?
Yeah, corrugated graft is not 100%. Its patency is around 60 to the 80% range. So this tissue graft is better than the PTFE, but still not perfect. Okay.
And then, do you think Dr. Dardik had a question in the chat about whether or not these this sort of reinforcement could be added to other graft material, in fact, even biologic graft material, such as a saphenous vein or cephalic vein or something?
Yeah, that's a great idea. Yeah, it could be possible. I think it's just a matter of how you attach this suture reinforcement into this biological tissue. Because the biological tissue is really floppy. So they maintain some diameter and they're wrapping around this suture in kind of homogeneous ways maintain some structure. Can be a bit challenging in the manufacture, but that's a great idea.
In the absence of additional questions, I think I'd like to move on to our invited speaker for this. Great talks from both of our presenters of their papers, and we at the JVS-Vascular Science very much appreciate your contributions to our journal and look forward to seeing future papers from you in your labs. So Dr. Roy is our invited speaker for today. She's an assistant professor of cardiovascular surgery at Houston Methodist Hospital, and she's working as an endowed investigator in the Gerald B. Katz Academy of Translational Research. Her education and training was at the University of Toronto, where she obtained a bachelor's degree in bioengineering, her medical degree, as well as a doctorate in MRI of vascular tissues. Of course, she was also trained in vascular surgery at the very prestigious Toronto Vascular Surgery Program. Her interest is in improving care for lower extremity arterial insufficiency, leveraging her expertise in MRI and biomechanics. She is working to improve our tools and techniques through a better understanding of the pathobiology of the blood vessels and their interactions with our interventional tools in that abnormal tissue. Dr. Roy, we're really privileged to have you talk today on vessel imaging, morphology, and endovascular device interactions with the vessel wall. Thank you.
Thank you so much for having me. I'm excited to be here. My undergrad, it was in bioengineering, but it was materials specific. So this has been right up my alley. Very excited to be here. So I'll talk a little bit more about vessel wall morphology and how that can impact our device selection. I'm a 50-50 surgeon scientist, as we were talking about. And I think this group, we know critical limb ischemia, huge problem. Right now, there's two ways we approach it: percutaneous or open surgery. So BASc CLI came out. It seems like bypass is better in almost all of the major outcomes. but it did raise a lot of questions already. So the question was that it compared it to best endovascular treatment. But what does that really mean? So peripheral artery disease, the plaques are very, very heterogeneous. What it's made out of really varies patients to patients. And we have multiple different types of devices that are designed specifically for specific types of materials. But right now we can't tell these apart, and we treat everyone the same. One of the things that's been pointed out was there was an immediate technical failure rate of 15 to 20%. And I think that that is actually truly reflective of our clinical practice. I think we see the trials and it's 99% technical success, but really with these critical limb ischemia patients, this is a high failure rate. And the most common mode of failure is the inability to cross a lesion because it's too hard or too stiff to get through. So this is something I think we should be able to know in advance. Okay, so right now we're going in very blind where, it's like if you're going to drill through a wall, you need to know what it's made out of. If it's concrete or plaster or wood, you choose different drill bits to be successful in getting through that. If you choose the wrong one, you can create a lot of damage to the wall. And here we're talking about delicate blood vessels. And I think it's really key that we understand what we're getting through and do that with imaging. So the three basic steps of any intervention: we cross, we open, and then we want to keep it open. So talking about crossing, I think that that's something that we focus on with our MRI techniques and developing ways of identifying who is going to be at high risk of endovascular failure. And this is just a perfect example of one. So this is one of my patients. We did a CTA ahead of time, significant occlusion in the adductor hiatus, but not at all calcified. You present it, everybody thinks, okay, this is going to be super soft, easy to get through, no problem. So we do our RPVI attempt, which was the standard of care, just not too long ago. But it ended up being super, super hard, even though it's not calcified. We need to know whether we're going to go through butter or rocks beforehand. You can't tell on CT or other imaging. So we fail. And then we go ahead and do the bypass. We know that bypass after endovascular failure has higher failure rates, higher 1-year amputation rates. So we are burning bridges with this approach. And then eventually she required an amputation, and we looked at the histology of the lesions, and it was in fact dense collagen. Now she was entered into our study and had preoperative imaging with our MR techniques, but we were blinded to these for our interventions. And we see that it actually was a plug of dense collagen that you can tell on the MRI. And how that works is it's a new group of sequences called ultra-short echo time sequences. And I'll walk you through a little bit of this, but right now, if you look at most of the MRI sequences, it looks like you can't see calcium, right? Calcium is a signal void. It looks dark. And the reason for that is calcium doesn't have much water in it, so less protons, and it's a very hard packed material. And because of that, the signal intensity decreases really quickly. So this is an example of that same lesion. And depending on when we're capturing the picture, we can see different types of materials with different contrasts. So here we're capturing it very early after our pellets. And at this point, the collagen and muscle, they both have relatively the same amount of signal intensity. When we image again at a regular echo time, a little bit later, we see that collagen really drops off and muscle stays very similar, And with that, you can use the signal behavior to really tell us what are the materials making up these plaques. And so we showed that that does relate actually in ex vivo puncture force testing, and we did a clinical study on that as well. And we're working on more generalizable techniques so that we can do this more. So then the next piece is, how do we open this? Okay, so we talk about when you are really dealing with heavily calcified, rigid vessels, when you're inflating balloons within them, you're requiring very high inflation pressures that causes barotrauma to the vessel wall, and you can have uncontrolled dissections. These are not always obvious on angio. We don't see it, but at least 70% of the time you're having these dissections, and that's thought to be related to why these interventions don't last. So a whole host of devices have come out for vessel prep, okay, and the goal of all of these are to either break out the calcium or core out the calcium so that the vessel wall is more compliant, such that when you do your ballooning, you don't have that same amount of barotrauma. You can do low pressure inflations, and the vessel is much more compliant. You know, none of these have shown benefit. But there's a big difference between different types of calcium. It matters if it's a nodule or sheet or fragments. All of these things will impact how successful a device will be. And this is an example of a control. This is a segment of a diseased vessel, and it's a micro CT in 3 views. And I just wanted to show, just even along the length of it, how heterogeneous it is, how you have a lot of these vacuoles and areas of discontinuities just naturally within the vessels. So maybe that's why, you know, when we're just doing micro cracks or things like that, it may not be as effective as we would hope. But we want to study this robustly. And so we developed a way of imaging cadaveric legs and then testing devices in those legs. So this is our setup. So really lucky here to have a 7 Tesla MRI. This enables us to do high resolution imaging, 3-dimensional, non-invasive, right? So this is before we ever touch the blood vessel. We can see at 0.2 millimeter isotropic resolution, what is the actual occlusion lesion made out of. Then we take the vessel to the whole leg to the OR, and we do it exactly as you do in our patients. So get through and through access in this case. We then will balloon it, either plain balloon angioplasty, or we'll do vessel prep with shockwave or orbital atherectomy. And then angioplasty, seeing if there's a difference there. And then we also have a control segment. And then we harvest it. We look at what did it do to the vessel wall on micro CT for the areas of calcium, and then histology for all of the other components. And so this was feasible in 14 out of 15 legs. One of those we couldn't cross intraluminally, so one of those immediate failures. But I just wanted to show you a little bit of the differences we can see with this. So this is a control specimen. You can see also either, you know, an open or stenosed vessel. You're going to see this really healthy layer of endothelial lining, at least a complete layer of endothelial lining there. Now, when we did an angioplasty and just ballooned it at the nominal pressure, you had immediate recoil. It looked like you did nothing to the vessel wall. When we actually did an angioplasty based on getting it to a profile based on the angio itself, this is what we did to our vessel wall. And we had major plaque disruption. And it was really quite surprising because when you looked at the angio, it actually looked pretty good because your lumen's nice and big now. But yeah, we're really doing some significant damage to the vessel wall. This is what we saw with the shockwave so far, at least in this intervention. You know, not much difference. We did get a lot of recoil still. And then with orbital atherectomy, we saw that you had this preserved ring where you're not getting those uncontrolled dissections. But you also do see that you end up stripping the whole endothelium in the process. So what are the long-term implications of that? So we need to, you know, one thing is the immediate effect on the vessel wall and understanding what a device does to a blood vessel. Another is, what does it do over time? And of course, that's the key question. And I think that this is a really exciting area for us because the MRI techniques, they don't require any contrast, any radiation, so you can safely follow patients over time. So we can characterize them beforehand and actually image them over time to see how the vessel wall responds. And I think that that will give us really necessary information to make our interventions more successful. So I kind of show this current standard of care. We have pretty high failure rates, treating everybody the same. I think that with advanced imaging, we can parse out who's going to be a good candidate for endo, who should be a bypass candidate, and if we're going to do endo, what's going to be the best device the first time. So thanks to a lot of people who contributed to this work, and yeah, thank you for the opportunity to present our work.
Wow, congratulations. Yeah, exactly. This is really thoughtful approach to something that, as I sort of said at the beginning, we've been taking a pretty blunt tool set to, and this is going to refine our ability to think about how we use our tools in a lot of ways. So we had some really good questions here. I'll kind of hit on some of these. Dr. Dardik asked whether or not an MRI techniques that you're using here could be done on our clinical machines, or does this require some sort of special machine like a 7 Tesla or a software upgrade of some sort?
So the MRI technique where I showed the patient study, so that one is like 0.5 millimeter resolution. And we're able to do that with stock sequences. So I developed this all in Toronto with prototype sequences, very specialized things. Here in Houston, don't have those, right? But we have stock sequences that can show us those. So you're not going to get the same level of detail, but you can identify who's going to be crossable or who isn't going to be crossable. I think that the 7 Tesla MRI, it's FDA approved. It is a clinical scanner, but I think right now the role of it is really getting an understanding of the vessel wall response more in a research standpoint.
So you used these different tools and looked at the histology in this sort of setting. We know that atherectomy, even though it sort of ends up looking better, still doesn't really move the needle on patency in the longer term. So what features of histology do you think we should be focusing on when we do this that might better predict those treatments that would be more effective and durable?
So we're looking at a few things. One is dissections. Is it the intima, media? How bad is the dissection? How much are we, disrupting the vessel wall? So that's one piece. But I do think an important part is the endothelial lining. So that's what I kind of pointed out there, because now we're creating, we're stripping the whole non-thrombogenic surface of our blood vessels. And I think that that's having consequences. So I think that that's something we're looking as well at the histology for.
All right. So we had a couple other questions regarding the current state of the art with regard to crossing and whether we're actually burning any bridges when we do that percutaneous intervention from Dr. Schwartz. Do we really change the biology or the anatomy in such a way that it reduces long-term patency and limb salvage in these patients? Do you want to address that, or is that?
I think that so I wrote a paper on this called "Burning Bridges." So we don't know for sure, okay, but there are big studies in the the New England group, basal trial, so on and so forth, where they showed the higher 1-year amputation if you've had prior failed ipsilateral intervention. I think there's a few different ways why that might be the case. I think we distally embolize almost every time, and it's not visible. I think that we're making dissections and those kinds of things that could be uncontrolled, and that could be causing some issues as well. I just don't think that these interventions are as benign as we think they are, because angio shows you so little. You don't really know what you're doing to the vessel wall.
Excellent. Well, this has been a fantastic group. I'm going to turn it back over to Dr. Dardik to kind of close us out.
Thank you very much, Dr. Curci. I'd primarily and firstly really want to thank our presenters, Dr. Schwartz, Dr. Hibino, and especially Dr. Roy. We really appreciate these wonderful insights to science, and this is the foundation for how we take care of patients. I hope that everybody has enjoyed a glimpse into the future of what I hope our patients can benefit from in the future. I'll once again thank Dr. Dahlman for joining us, the new head of brands of the journals of vascular surgery. Thank you so much. And again, thank you to Tyler Cosgrove, Paul DiMuzio for supporting, and hopefully we'll be able to see this webinar on the JVS Vascular Science homepage, www.jvs-vs.org. Please visit us and visit often. Thanks again and have a good night. Take care.
Thank you, everyone. Bye-bye.
Bye-bye.